case-based situations or a tailored approach. Again, on DME, we can spend the entire day discussing different protocols, but my job here is to just present to the audience some of the difficult situations. I'm not presenting situations where patients achieved 20/20, everything was fine, but to generate a debate as to how we all would manage in different situations. Again, I would like to thank my previous speakers, Drs. Purnima and Dr. Ritesh, for having made my job easier because I don't have to go through the details of various protocols. By way of financial disclosure, I am a consultant to Novartis and Allergan. And I'll just briefly mention here that the key protocols which have been helping us today in present day practice or guiding our protocols, I and the MEAD study which was on Ozurdex. But then protocol T, which has been mentioned earlier by Dr. Purnima, will become important in the future, which compared head-to-head aflibercept, Avastin and Lucentis. So, although the 2-year results were presented earlier just now of protocol I, I'm just going to show the 5-year results of protocol I. Just 2 slides, a couple of slides, just to make a point here that the better the visual acuity at baseline, if the patient has 20/50 or more vision, that is 65 letters or better, their gain in vision is about 5 letters. But if the patient's vision is less than 20/50 at baseline or less than 65 letters, they tend to gain more. And this is true across all trials and all diseases, in fact even for CRVO, BRVO and also DME. Worse the edema, worse the visual acuity at baseline, more is the gain that you will see. We're not talking about the final vision, but the gain in vision is much more if they have a better or worse baseline visual acuity. But this is the overall final visit data at 5 years of these patients. We're just showing the prompt laser and the deferred laser plus ranibizumab groups. Slight edge of the deferred laser or prompt laser, but again we also have to see whether the number of injections had any difference in these two groups. If you add prompt laser in these patients, that's probably one of the key questions as of today for all retina specialists. We understand frequent injections, visual acuity is what is this much, but can we somehow reduce the frequency of injections, whether it's steroids or even if it's anti-VEGF? Can we just have a protocol of not just injecting every time you see edema or a cyst, do you have to inject? Does it serve any purpose? So at least here in this protocol I, at the end of 5 years, the number of injections was slightly less in the prompt laser group. Slightly less, just 2 injections less, 13 versus 11 or so, that's what I remember. But in terms of visual acuity differences, it's not much. And if you ask me in terms of the number of injections, it's a debate whether these 2 injections made a difference. And this difference was not in the first year. First year they all received 9 injections or 8 injections because it was mandated that 4 injections were compulsory in the initial 4 months. There are other trials. Bold study had 3 injections mandatory as a loading dose. So it's up to us whether you want to have a PRN criteria from the beginning and have your own evidence-based protocol. But as of now, all the evidence that we have, whether it's protocol I or the Bold study, they all have given loading kind of doses, 4 injections and 3 injections, which increases the burden of injections in these patients. By the way, in the 3rd year in the protocol I, patients received only 3 and 2 injections in deferred laser and prompt laser. But the other good point which we got from protocol I was, or even from other trials, was there was no increase in macular ischemia based on FA, the anti-VEGF injections. This was always a concern for all of us, whether anti-VEGFs will increase the macular ischemia. They did not increase macular ischemia. These are the other options which I will be discussing briefly in case-based situations. The first patient is right here. This was a 51-year-old gentleman who had all the problems associated with diabetes, that is hypertension, hyperlipidemia, which were under control, but HbA1c was 7.8. Now 7.8 by Indian standards is not bad. We have 10, 11, 12 HbA1c kind of patients. But yes, 7.8 is not ideal, definitely has to be brought down. So what happened after that? Patient's presenting vision was 20/80, near vision also very bad in the right eye, left eye was okay. This is what you see, the fundus photographs, a lot of hard exudates. But the main point here is, nowadays we are moving away from talk of CSME. I know that none of the previous speakers have given the textbook definition of clinically significant macular edema, which we have all learned earlier. We are talking about DME, central involving, non-central involving. How do you treat them? So as you can see here, the right eye, central involving, left eye, non-central involving, and also the vision is obviously different. You see the FA late phases in the right eye, diffuse macular edema, left eye, focal leakage, but not diffuse macular edema. Right eye, extensive thickening, left eye, nothing. So now in the right eye, at this point of time, we had advised Avastin at the time. Left eye, I thought, let's see, it was a bit far away, more than one disc diameters. Let's see if we can observe with good systemic control. And what happened after one Avastin? Nothing much, from 850 to 650, but it's not what we wanted. And left eye started developing edema. Now you can see on OCT, although clinically it may not appear, as if it's central involving, but the OCT has started to show it changes. Now what we advised was right eye also we had advised injection and modified grid laser, left eye Avastin and focal to microaneurysms, and the patient improved. You see the vision 20/40, left eye 20/20, and this is what was after the third injection in the right eye and one injection in the left eye. Edema is worsening in the left eye, not improving, after focal laser and injections. So the right eye is showing some improvement after 3 injections. But the patient was lost to follow up, not unusual in our part of the world. Patient comes for 2-3 injections. Obviously, it could be monetary reasons that they are not coming back, or any other reason they are disappointed with the results or the outcomes and they are lost to follow up. Then they come back again. And this patient came back, but HPA1C of 9, worse systemic control. The vision is still holding on in spite of having 300 edema and also in the left eye. The vision has not deteriorated that much. But now you can see both eyes are central involving macular edema. But see the OCT, extensive edema. Now this edema, the patient has 20/60 in the right eye, 20/40 in the left eye. It's surprising sometimes. We have been following, we are also doing a lot of trials, following every month injection, but somehow when the OCT doesn't improve, with severe edema also, some of these patients could even have 20/20, 20/25 vision. It is a surprise, but yes, this patient had 20/60 in the right eye and 20/40 in the left eye. I'm just giving a summary. I'm not going to go into the details of what happened. This was, say, about 2 years of follow-up that this patient had multiple injections, and you see the right eye, small separation of the hyaloid from the fovea. And now I'll tell you what happened. This is after 2013. The patient has received now 4 intravitreal triamcinones in the right eye, 1 Ozurdex in the right eye. But ultimately, the edema didn't improve. With IVTA, the first injection he improved, but then after the recurrences, he never improved with subsequent IVTAs. And the patient had developed a vitreomacular traction, underwent vitrectomy about 4 months ago, still under follow-up. I thought vitrectomy would help in such patients. Normally, the vitreous is a reservoir of VEGF, so you remove this vitreous, the edema should subside. I did an ILM peeling also, but still the patient has a lot of edema at this point of time with 2200 vision. So we have tried all kinds of things, not a great outcome for the right eye. But for the left eye, this is for the first 2 years that I am showing, but then this patient has received 3 IVTs, is doing well in the left eye. On the right eye and the left eye behave differently, although VMT developed in the right eye, but the outcome in the left eye has been much better with 20/40 right now. Now just changing gears to another case where we have a common scenario, cataract and DME. It's a debate which everyone, the cataract surgeons want to push it in some way, retina surgeons want to deal it in a different way. Let's see how this patient showed up. So this 53-year-old gentleman, way back in 2007, when anti-VEGFs were not in vogue for DME at least, 20/20/20/25, left eye, posterior subcapsular cataract, non-central involving left eye, patient underwent focal laser in the right eye because there was central involving DME. Even though vision was 20/20 or 6/6 in the right eye, 6/6 is not the criteria to decide treatments. Whether it's 6/6, you could still be going in for treatment because especially the right eye had center involving DME. Left eye vision was less because of cataract. Now, patient underwent phacoemulsification, and by the way, if someone recognizes this handwriting, this is Ritesh Narula's handwriting on the left eye, way back in 2008 when he was a fellow with us. A patient developed center involving macular edema in the left eye, 125 vision. The first day was 2020. This is what we had status at that time, subretinal fluid, macular edema. And as I mentioned, at that time we didn't have, the practice of anti-VEGF for DME. We had started for ARMD at that time. Patient had focal laser in the left eye, macular laser in the left eye. Patient improved to 20/64, doubling of vision. In the interim 2 years, the diabetes was stable. See the vision in the left eye, 20/30. Now we keep talking now lasers, EFI role, not good, only anti-VEGF. But this is one case where maybe not all cases have such good outcomes. But laser in the left eye, the patient had a good outcome in the left eye. Now see the cataract in the right eye, 20/50. Underwent cataract, first day 2020, starts developing macular edema, subretinal fluid, one injection, didn't improve. Then one IVTA steroid, patient improved, edema improved 20/40, again came back. One more Avastin, worsened, loss of compliance, and this time from 2020 he has come down 2200. One more injection, no improvement. What we decided now was vitrectomy with ILM peeling in this case in the right eye. 20/64 after 2 months, and then after 6 months or so, the vision has come back to 20/30. Slow recovery, but if you see the ILM peeling in such cases is difficult. Because I will just wind up. This is the edge of the ILM peel here, and there's some ILM still pending over here, there's some ILM still over here. So wherever this ILM is still present, the edema is slow to resolve. This is a case of VMT. Now I'll skip this video. It's not much relevance to this case. Now we also have Navilash laser, which Ritesh had pointed out. We are doing a trial called CavNav laser. We also have micropulse laser in this. So we have one more addition now after grid laser, focal laser, micropulse laser, and then subthreshold laser, non-micropulse. We have all kinds of confusions right now. I'm not going to discuss anything about the accord, just I had added initially in case we had not touched earlier. So in conclusion, DME response to anti-VEGF steroids in long term, the MEAT study showed that pseudophakic patients at least they had a significant improvement vision. Even protocol I, IVTA, the pseudophakics who were at baseline had comparable outcomes to ranibizumab. And the MEAT study showed the number of injections was only 3.1 over 3 years. So that could be a benefit. If you have a pseudophakic patient, not glaucoma, you could go in for steroids. Role of laser, still not clear, but has a definite role in non-center DME. Cataract surgery in DME is still a challenge. Thank you very much for your kind attention.
Any